Unit 3, Lecture 2, Provision of Care and Setting of Care. This second video lecture is focused on the role of healthcare professionals in providing care, explores the cultural challenges that the shift from cure to care requires, and promotes reflection on the settings which provide care and how the context may influence the type of care provided. This lecture will answer three questions. The first one, which are the characteristics of care? The second one, which cultural transitions does the care require? And the third one, where is care acted and how the setting may influence care? Patient-centered care implies that healthcare professionals should respond to their patients' preferences, including the preferences for involvement in the decision-making process. Yet, the nature of such preferences and how these have changed over time remains contentious. A recent survey shows that about a quarter of patients prefer a passive role. Instead, familiarity with a clinical condition increases the desire for a shared role. Preferences for a passive role versus a shared role varied across settings, with older and less educated individuals being most likely to prefer passive roles. A recent study showed that often nurses prefer a passive patient who complies with therapeutic indications. The good patient is conditioned by the degree of submission that the patient acquires in the relationship with the nurse. In order to be considered a good patient, characteristics such as accepting the disease and not continuing in denial, not requiring too much information, accepting the rules and norms of the institution, as well as valuing nursing practice, should be present. Instead, a bad patient is a difficult patient who denies disease, has excessive care demands, and rejects the proposed care. The passive role of the patient achieves its maximum expression in hospital, where the patient is assumed to lack autonomy to participate in their care and decision regarding treatment. This phenomenon is affected by several other factors, including interprofessional relationship, the health institution, care models, and length of stay. Several guidelines stated that spirituality is an important resource for coping with illness. So, we ought to integrate spiritual care in the hospital. However, it has been poorly studied if patients really expect to discuss their spirituality while they are in hospital. A recent study in a public French hospital interviewed 20 participants with advanced cancer. Findings show that the patients do not expect help from the hospital to handle spiritual issues and wish for their spiritual dimension to be simply recognized as a part of their identity and dignity. Findings invite us to view the question of spirituality not as a new dimension of care, but as a new challenge for healthcare institutions to recognize that the persons healthcare professionals are caring for are not just patients, but human beings with a precious interior life. In a recent review of 11 studies describing clients' perception of their spiritual needs in healthcare settings, 6 primary spiritual needs, which were often intertwined, were identified. A family of spiritual needs was associated with the client's relationship with God. For many people, this relationship was the means through which they made sense of their current situation. Directly related to this theme was the need to engage in spiritual practices, which can be understood as specific regular activities that foster clients' connection with the transcendent. Among these were the need for or to engage in prayers, Bible reading, meditation, reflection, and religious services. Interviewees also reported a spiritual need for connection with other people, such as visiting with family members, conversing with people who share one's spiritual values, seeking forgiveness from people one wronged in the past, processing events with others who had similar experiences, receiving tangible expression of support and encouragement, and also being appreciated and loved by other people. And finally, someone simple physical presence was extremely appreciated. Relationship with healthcare providers instead included friendly facial expression, words, and body language, as well as interaction that communicated dignity and respect, empathy and caring, complete and accurate medical information, the opportunity to discuss treatment options, and finally, trust and integrity. The philosophical anthropology proposes that human persons are intrinsically spiritual. This is based on a notion of the human person as a being in relationships. According to this perspective, illness is a disruption of right relationship. And particularly, according to this model, illness disturbs more than relationships inside the human organism. Illness disrupts families and workplaces and shatters pre-existing patterns of coping. Illness disturbs relationship both inside and outside the body of the human person, and disturbances are twofold at both levels. Inside the body, illness affects relationships between and among the various body parts and the biochemical processes, and also affects relationship between the mind and the body. Outside the body, illness affects relationship between the individual patient and his or her environment, including the ecological, physical, familial, social, and political nexus of relationship surrounding the patients. Moreover, outside the body, illness affects relationships between the patient and the transcendent. Therefore, a holistic approach to healing requires attention to the psychological, social, and spiritual disturbances to consent a personal growth. Organizational factors are also of importance when addressing spirituality and spiritual care in healthcare settings. Traditionally, end-of-life care settings such as hospice and palliative care services show a higher level of spirituality. Instead, with regard to other care settings, a recent survey among Turkish nurses showed that nurses in pediatric and psychiatric departments reported higher sensitivity to spirituality and spiritual care compared to other departments. Moreover, another study involving 400 Dutch hospital nurses, mental health nurses, and nurses in home care settings found nurses who work in mental health care and home care to have a more comprehensive view of spirituality and spiritual care, and report a higher level of spiritual competence compared to nurses in hospital setting. This suggests that the organizational context may influence the quality of the spiritual care provided to patients.